ikinci medikal cerrahi endokrinoloji toplantımızın bu oturumuna hepiniz hoş geldiniz. Hepinizi saygıyla selamlıyorum. Şimdi Doktor Amir Hamrahian, kendisi Cleveland Klinik Endokrinoloji Cerrahi kürsüsünden bize geldi. Subklinik Cushing ile ilgili görüşlerini bize aktaracak. Aynı zamanda Hacettepe Üniversitesi'nden derecesini almış bir hekim. Kendisi sunumu İngilizce yapacak ama ondan sonra sorularınızı kendisine Türkçe'de aktarabilirsiniz. Hepinize şimdiden katıldığınız için teşekkür ediyorum. Please, Mr. Hamrahian, you can go on.
Good afternoon. I want to thank the organizing committee, Dr. Berber, for their kind invitation. It's an honor to be here today. So, don't have any conflict of interest pertaining to this presentation. Whenever we come across an adrenal incidentoloma, there are two main questions to answer. Number one is that is it functional, and number two is that whether it is malignant, whether primary or metastasis. We need to check for pheochromocytoma and subclinical Cushing syndrome in all patients with adrenal incidentalomas. However, only patient with hypertension needs to be checked out for the primary aldosteronism. There are a few reports about patients with the hypokalemia but no hypertension that has found to have primary aldosteronism. But as a general, these are almost always hypertensive. So my talk is I'm going to go over some historical background about this terminology, these diagnoses. Talk about its definition, prevalence, how the diagnosis is made, associated comorbidities, and the treatment. So Bierwalds in 1973 was the first one who described two cases with adrenal incidentoloma who had on scintigraphy and unilateral uptake that only increased on the contralateral side after 9 days of ACTH stimulation. Here it is after the dexamethasone suppression, and here after giving 9 days of ACTH, they found that there was uptake on the other side. There was no evidence of Cushing syndrome in this patient. Later on, Charbonnel in a paper described a case of a 50-year-old man during a urological evaluation that found to have adrenal scintigraphy showed an uptake in the right adrenal gland, but the left adrenal gland could not be seen on the scintigraphy. However, after giving 11 days of a 500 microgram ACTH, cortrosine, they were able to show the uptake in the left side. This is the left side, and this is the right side. So there was absolutely no evidence of Cushing syndrome on the history. What used to be at that time 17-hydroxycorticosteroid was normal, but the patient had the undetectable ACTH level. He refused surgery for 5 years with clinical examination being unchanged. The patient after 5 years undergoes surgery. The patient develops adrenal insufficiency after surgery, which recovers after 8 months with a normal ACTH level, which was suppressed before. And the repeat scan showed uptake in the left adrenal gland, which could only be seen after ACTH stimulation before the surgery. So the authors brings up the question that this condition of subclinical Cushing syndrome may represent something similar to a pretoxic or subclinical hyperthyroidism from a toxic nodule that you may see. And they brought the issue up that whether all cases of Cushing syndrome due to an adrenal adenoma are preceded by this condition. So I had the pleasure of being a part of the ACE guideline for adrenal incidentalomas. And the definition of the ACE, American Association of Clinical Endocrinologists, for this condition is that it's characterized by subtle autonomous production of the cortisol by an adrenal tumor, which is usually associated with suppressed production of cortisol from the contralateral side, but no overt clinical features of Cushing syndrome. It is important, in my opinion, to know that when we talk about subclinical Cushing syndrome, we are not talking about a silent corticotroph adenoma in the pituitary gland. We are not talking about an ACTH-dependent macronodular adrenal hyperplasia. We are not talking about PPNAD, primary pigmented nodular adrenocortical disease, a patient with Carney's complex. We are talking about patient with most of the time, almost all studies, the majority with the adrenal incidentaloma with a normal contralateral side. The biochemical study may be similar in all these conditions, but the approach is different. Here, doing a unilateral adrenalectomy will not cure the patient. The levels will go down for some times, but after a while, there will be increasing the levels again. So the approach is different in this condition. So when we talk about subclinical Cushing syndrome, we refer, at least I refer to this condition, and not a patient who can have the similar biochemical evidence, but with the bilateral pathology or a pituitary pathology of a silent corticotroph adenoma. So how common is this condition? This is a famous study by Montero from Italy. In 26 centers, they look at the adrenocentaloma survey. They did a survey, and they found that having at least 2 or more basal or dynamic abnormality, the prevalence was about 9%. Looking at the meta-analysis that was published in 2000, here you can see the prevalence ranging from about 5% to 20% with a mean prevalence of about 8%. My experience using a bit more conservative criteria is about 5%. Now, one thing needs to be clear. When we talk about in the absence of a typical features of Cushing syndrome, what do we refer to? In my opinion, the skin manifestation is really what makes as an overt Cushing syndrome diagnosis or suggestion of that. I mean, to me, these are the main things that when I look at the exam of a patient, I look for them to have a high clinical suspicion for Cushing syndrome, including ecchymosis, pathologic stria. Here is a patient, for example, before and after surgery for Cushing syndrome. What makes me think about Cushing syndrome in this patient are moon face and facial plethora, and not the abdominal obesity. I mean, that is very common that you can see in many patients with the obesity in our obesity clinics. So when we talk about in the absence of a typical features of Cushing syndrome, I usually refer them to skin manifestations. When you look at the literature, there have been a wide variety of the criteria used for this condition. They have used different doses of the dextrosuppression test, the 1 milligram 2-day low dose, 8 milligram overnight, or 2-day high dose, with a different criteria ranging from 1 to 5 microgram per deciliter, for example, for a 2-day, 1.8 to 3 microgram per deciliter. And I'm surprised. I mean, we diagnose Cushing syndrome. For example, I diagnosed Cushing syndrome with a cortisol less than 1.8 or 1.4 after 2-day low-dose dexamethasone administration. How can you diagnose a subclinical disease with a 3 microgram per deciliter criteria? They have also used a wide variety of other tests, including 24-hour urine cortisol, the low or suppressed ACTH, elevated late-night salivary or night serum cortisol levels, abnormal diurnal variation, and abnormal response to CRH. And as you can see, these are not practical in many practices. I mean, you can admit the patient for a late-night serum cortisol or measure the diurnal variation. So these mostly can be done as a research protocol, but not in the main clinical practice. So what is the best test to diagnose this condition? In my opinion, there are three gold standard or semi-gold standard way to diagnose this condition. And I don't know any other way. If you know any other way, let me know, and I'll be more than happy to learn about it. One of them would be adrenal scintigraphy. Difficult to do, it's not available in the United States. It causes radiation exposure, and we don't have it. I don't know if you have it in Turkey or not. One of the other criteria that can be used would be post-surgical adrenal insufficiency. Unfortunately, the majority of the studies have not looked at these after surgery. The reason is that, and actually I had a hard time also to convince our surgeons, but they are afraid that the patient will develop adrenal crisis if you do not give them a steroid during the surgery and measure AM cortisol. They will not develop any problem. This is measuring AM cortisol off giving any hydrocortisone to the patient during surgery is safe. You can measure AM cortisol next morning, and then you can start the patient on glucocorticoid till you get the result back. And the other one would be the improvement of comorbidities after surgery. These are the three ways that you can kind of help you to define this syndrome. So let's look at some evidence by adrenal scintigraphy and by improvement of association of the comorbidities with this condition. This is a study again from Italy. 31 patients with a benign adrenal adenomas more than 1 centimeter had the adrenal scintigraphy done. 61% had unilateral disease and 12 had bilateral uptake. None of the patients showed the specific findings for the clinical features for Cushing syndrome. The hypertension and obesity was present in about 50% of the patient, and about 16% of the patient had diabetes mellitus. So what they found that the urine-free cortisol among this group, these are the patient with a unilateral uptake and the patient with bilateral uptake. The urine-free cortisol were similar. This is a RIA assay, normal is 2200. So there were, although the levels are higher, but these were not different between the two groups. However, when they look at the ACTH levels and they look at the cortisol post 1 milligram dex suppression, there was a significant difference between the two. There were also difference between in the cortisol levels at midnight and looking at the diurnal variation, the midnight to morning one. But again, this is something that not easy to do in the most clinical practices. In another study of 83 patients with solitary adrenal adenomas, the investigators again from the Italy Barzone, they divided the patient on exclusive, prevalent mean on one side having more uptake than the other one, or symmetrical uptake. And they found that all patients who had a cortisol more than 5 microgram per deciliter, they had exclusive uptake on that side. There were some other patients also who had the exclusive uptake whose cortisol was lower. But if you look at, for example, in the symmetrical uptake, 85% of them had a cortisol less than 1.8. Again, suggesting that a higher cutoff value of 5 microgram, at least based on these adrenal scintigraphy studies, may avoid too many false positive results. So what about the cardiovascular risk factors? These are some of the comorbidities associated with excess cortisol, hyperglycemia, hypertension, hyperlipidemia, obesity, and also osteoporosis, vertebral fractures. In an important study by Morelli, many of these studies are from Italy, and actually Turkey has also contributed to the literature on this topic, which I'm going to touch about it very briefly. But in this study, 231 patients with unilateral adrenal incentaloma, 120 men and 111 women, they look at the comorbidities of diabetes mellitus, hypertension, and vertebral fracture. These were the percentage present in these population. The mean adenoma was 2.5 centimeter. It was positive correlated with the cortisol level doing 1 milligram dex suppression test. These are the correlation coefficients, UFCs, and the negatively associated with the ACTH level. As you can see, the correlation coefficient was the highest with the cortisol post 1 milligram dex suppression test. It's a busy slide, but the reason I'm showing that the investigators came and look at 3 different cortisol values during 1 milligram dex suppression test. They look at the ACTH values and the UFCs. They also combine these different cortisol criteria with the ACTH, low ACTH values and UFCs, and also they look at all 3 of them or 2 of the 3 of them. So now here they are trying to correlate these tests with the patient who had all 3 comorbidity present in their history. First of all, comparing the 1 milligram dexamethasone test with the UFC and the ACTH level, only the cortisol after 1 milligram has significant correlation with the number of the complication. Again, suggesting that this test is a better tool to evaluate this patient compared to the UFC and ACTH levels. So looking at these different criteria, 1.8, 3, and 5 microgram per deciliter, they found, as you expect, if you use the 1.8 microgram per deciliter criteria, you have the highest sensitivity. You will be catching the majority of the patient. If you use the 5 microgram, you have the highest specificity. You try to avoid misdiagnosed normal patient as having this condition. The best combined sensitivity and specificity was provided by using a criteria of 2 out of 3, the 1 milligram after above 3 microgram per deciliter, high UFC and a low ACTH, 2 out of these criteria. So this was provided the highest combined sensitivity and specificity. But however, if you look at it, you can also see that if you use just the criteria of 3 microgram per deciliter, the numbers here are very similar to the numbers provided by these 3 studies. In an important study by Coyodini, I hope I'm pronouncing the name correctly, the investigators look at the patient who had the subclinical Cushing syndrome based on the 2 out of the 3 criteria, the one that was by Morelli showed they provide the best combined sensitivity and specificity. And they look at the patient who had surgery versus who did not have surgery done. And these were followed for 18 to 48 months. Here, there was no randomization. The patient chose to have the surgery. And as you can see, the younger patient were more likely to have surgery compared to the older patients. So the baseline characteristic for both these groups who had surgery versus did not have surgery were very similar. BMI, waist circumference, diameter of the tumor, and follow-up months. Also, their ACTH level, the cortisol after 1 milligram dexamethasone test, and the UFC were also similar. When they look at the result, and these are the number, again, these are not the biggest number, but these are the data that we have in the literature. They found that although the patient who had surgery lost about 2 kilograms, and the patient who did not have surgery gained about 1 kilogram, but the differences were not statistically significant. Also, the lipid panel were similar. However, when they look at the systolic blood pressure, comparing the last follow-up with the baseline in these groups, look at the diastolic blood pressure and look at the fasting glucose, there was significant difference between the 2 groups. Interestingly, there are some studies have shown association of the non-functional tumor, but Dr. Jenner from I believe, Dokuzelu University, Dr. Erbil from I believe, Chapa University, they have shown some association between non-functional tumors and some of these comorbidities, including hypertension, in one study at least, the carotid intima thickness, and I believe the endothelial dysfunction. However, there is some discussion about really whether all the patients in their papers had truly non-functional tumor, because some of the criteria they use may not be, they may not suggest that all of these patients were non-functional. But there are some studies interestingly that suggest that even in the absence of the subclinical Cushing syndrome, there may be some benefit improvement in some of these comorbidities with surgery. So what about the bone mineral density, vertebral fracture data? I just briefly talk about one of them, 287 patients. That's a lot of patients to have in the studies. And 194 control. These are the patients who went to the clinic with a thyroid nodule. They had a normal thyroid function test, and they used them as a control. It was a retrospective studies, and the subclinical Cushing syndrome was diagnosed, again, in the presence of 2 out of 3 criteria that most European endocrinologists use. irrespective of the sex and the menopausal status, there was significantly increased vertebral fractures. Again, these are the radiologic findings. Not all of these were clinical significant ones, but these are radiologic findings showing more than 20% decrease in the vertebral heights. That the patient with the positive subclinic Cushing syndrome were significantly had a higher fracture risk than those with negative and controls. And interestingly, you can see that the patient who had a premenopausal patient with the subclinic Cushing syndrome has a higher rate of vertebral fracture than a postmenopausal control and the one with without subclinic Cushing syndrome. And these data on vertebral fracture are kind of recently coming on, and I think it's important to consider that in your patient when you suspect this diagnosis. Before I wrap up the study that I wanted to talk about, I think it's important to talk about this study also. This is the only randomized study in the literature looking at the subclinical Cushing syndrome outcome. Out of 49 patients who were screened for this condition, 45 of them were randomly assigned to surgery or conservatively management. It is very hard to enroll a patient 45 out of 49 and follow them for a long time. I mean, I think they have done a wonderful job at least from an enrollment standpoint. The definition was having a cortisol more than 2.5 microgram per deciliter in all patients for this diagnosis, and at least one other abnormality of HPA axis. Patients were followed at 6 and 12 months, and the mean follow-up was 7.7 years. Very, very good follow-up. The two groups, the surgically treated one versus conservatively management, were similar in all parameters. The demographics, the prevalence of the diabetes, hypercholesterolemia, hypertension were all similar between the two groups. The investigators report the result in a funny way. They do not compare the glucose levels or blood pressure levels. They have divided these patients to who normalized, who had improvement or no changes. That's how they report the result, which I don't know why they have chosen this way, but that's the way the paper is written. So, first of all the patients with the abnormal DEX suppression test, which was the criteria, they normalized their cortisol. All the patients who had elevated UFC, the 9 out of 9, they normalized it, and all the patients with the low ACTH, they increased the ACTH. So it looks like what they treated was effective in normalizing the abnormal biochemical result. While there were improvement in diabetes, for example, in about 60% of the patient, normalization or improvement, and also in some patients with hypercholesterolemia, some of the patients, 3 out of 6, their BMI went less than 30, but these were not statistically significant. The only finding here was that the patient with the hypertension, about 65% of them, almost 70% of them had improvement or normalization of their blood pressure. In contrast, the group that did not have surgery done, they had the worsening of diabetes, hypertension, hypercholesterolemia in 33%, 42%, and 43% respectively. These patients were not submitted to any specific diet study or any specific education. They just was followed in the outpatient clinic without any education. Another important finding of this study, which also has been shown in several other studies, is that none of these patients who had subclinical Cushing syndrome went on to develop the overt Cushing syndrome over a 7.7 years follow-up. And this has been shown in other studies too. So looking at this condition as a kind of a bridge between the inactive to the overt Cushing syndrome is probably a very simplistic way of looking at things. Although there was some deterioration in the blood pressure and diabetes, but none of the patients developed overt Cushing syndrome. So based on what I mentioned to you, with majority comes from the adrenal scintigraphy studies and association with the comorbidities, the 1 milligram DEX suppression test seems to be the best test that we have for diagnosing this condition. According to the NIH workshop, recommended that to use the 1 milligram dexamethasone test as initial endocrine test for this condition. And to avoid too many false positives, they recommended to use a higher cutoff value. The ACE also, the American Association of Clinical Endocrinologists, also followed the same route and used, they recommended the 1 milligram and used the same cutoff value recommendation, again, to avoid too many false positives in this condition. They also mentioned a low or suppressed ACTH or DHEAS may also further support this condition. However, based on the comorbidities associated with these, the majority of the Europeans have used these 2 out of the 3 criteria of the cortisol more than 3, elevated 24 hours, or a low or suppressed ACTH as their criteria. And I can tell you that if today I write a review paper on these, in contrast to what I have said before, I probably would use a lower cutoff value of 3. I think there is enough evidence in the literature that suggests a 3 microgram would be a better cutoff value than 5. 5 may be too high. Another factors that you need to consider in your evaluation on this patient and treatment management probably is the age. And I agree with this kind of algorithm, although these age groups can be modified. I mean, you can use your own age group. To me, probably 40 or 45 would be a better cutoff value. So you may want to be more aggressive in the younger patients and consider in these people adrenalectomy. You may want to have a patient who are older, 70, 75, above that, in whom that the diabetes, hypertension is not uncommon in this age in population. You may want to follow them. And in the middle age group, in the case of any patient with a recent onset, worsening or difficult to control comorbidities, you consider surgery. Again, whenever we have a guideline is only a guideline. You as a clinician, as a surgeon, are the one to look at every case kind of separately, differently, and use your clinical judgment and come up. These guidelines are not the holy book that needs to be followed with us. So I usually also follow similar approach and consider age in my management strategy too. So in summary, the lack of a single gold standard test to diagnose subclinical Cushing syndrome is a challenge. I mean, the 1 milligram dexamethasone test seems to be the best one, but it is definitely not the perfect test. I think we can probably say with relatively confidence that if a level is more than 5 microgram per deciliter, especially in the presence of a low or suppressed ACTH, you have a diagnosis of the subclinical Cushing established. If the level is less than 1.8, in most cases, it rules out the diagnosis. And when you have a level between 1.8 and 5, to me, it makes sense to do further studies and look at other dynamic or basal values and go from there. I do not understand the reason why everybody should have all the 3 tests done. I mean, to me, unless you want to publish the data or you want to gather information, you may want to do that, and that would be fine. But if a patient, when you start with 1 milligram dexamethasone test and a patient has a level less than 1.8, you probably can stop there and don't do any further testing unless you think about a cyclic situation like that. So having all the UFC done, having an ACTH level done, and 1 milligram at the same time, it may be too much work if you have initially your level of cortisol after 1 milligram dexamethasone test come back as less than 1.8. The decision for surgery should consider the presence of the metabolic consequences as well as the extent of the HPA axis abnormality. The sicker the patient, the more comorbidities, I think it makes more sense to be more aggressive with surgery. All of these patients would recover their adrenal function, almost all of them, and will be able to have a normal adrenal function later on. So the more the problem is, I think it makes sense to be more aggressive in surgical approach. And accordingly, surgery may be considered in younger patients, in those with recent onset, worsening, or difficult to control comorbidities. I think I try to cut back on the slides to some more time for any question or comment that may have, and I think I would like to finish here. Thank you.
Thank you, Doctor.